magic of movement, specifically physical therapy for our young children, also including a little bit of pelvic floor and some additional specialty areas. Like Karen said, my name is Kelly. I have a doctorate of physical therapy, and I have been working at MetroEHS for about 2.5 years now. I have been in the realm of pediatrics for about 5 years. Today's general overview, just so you guys know what to expect, we're going to look at what is pediatric physical therapy, what physical therapy looks like specifically at MetroEHS, the difference between physical therapy and occupational therapy, specialty therapies offered at MetroEHS, so this will include that pelvic health and potty training, which I know much of you guys are interested in the most, and then how to get started. So if you are interested in scheduling with us at Metro, how you can go about doing that. So what is pediatric physical therapy? Pediatric physical therapy is truly an art. You have to be so creative to do it, but it's an art of helping children recover from illness or an injury, or just plainly assisting them in gross motor areas where they might be struggling. So typical adult physical therapy, you often think of, you tear your rotator cuff, you tweak your knee, doing a pickup game of ball, you throw your back out, unloading the dishwasher, something, and you're going to physical therapy to fix that illness and get back to your new normal. Well, for pediatrics, oftentimes they haven't reached their normal yet. So we work with these kids. Sometimes it is because of an injury, but oftentimes it's due to an illness that they got when they're younger, or a diagnosis, or they're just having some difficulties hitting those motor milestones and they haven't yet reached that new normal. So we want to work with them to get them to a new normal, or their normal, so that they can go about and live their best life. So our overall goal at MetroEHS is to maximize the child's gross motor movements so that they are functioning at their age-appropriate level, so that they can keep up and engage with their same-aged peers. My goal is always to, if I see a kiddo out in a playground or going to school, that they're able to do everything else that their friends are doing. I don't want a kid left out just because they physically can't coordinate their body or keep up. So physical therapy at MetroEHS is pretty unique. It's a big reason why I work here and love working here. We focus mostly on early intervention. So what that is more of that 0 to 3 age range, those really littles. Research shows that is when your brain is most neuroplastic, meaning we can make more neural connections and new pathways in that brain to help them learn to coordinate their body faster, retrain motor movements, which allows you guys to graduate out of therapy and get to your new normal life. That being said, we do see so many kids over the age of 3. Either things didn't progress until they were 3 and older, things came up as the child progresses and gets older. We love to always emphasize getting the kids in earlier and younger, because that's when we do see the most progress the quickest. However, we do see kids of all age ranges, so keep that in mind. At MetroEHS, we love using intensive-based therapy models. There's 2 different kind of ways to look at this. The main one that we use across the board is just high frequencies. Instead of, your outpatient physical therapy for adults, you might go in once, twice, maybe 3 times a week. At MetroEHS, we really strive to hit 4 or 5 times a week to hone in on how much of a sponge these kids' brains are and how quickly we can progress them and get them in and out when they're young. So we oftentimes really advocate for these kiddos to be in our centers 4 or 5 times a week, so that we can show the quick improvements and progressions throughout, so that you guys can go live your everyday life and not have to come see us every day. So that's the first option. And then there's another option for more specific type of situations, diagnoses, where a clinician might recommend, more than a typical 30 or 60-minute session. Maybe they recommend 120 minutes or an hour and a half, maybe 2 hours. It really depends. And your clinician at the center will help make that determination, but sometimes that is best for that child. At MetroEHS, we really, really hone in on play-based and child-led therapy. This is my favorite part. And parents oftentimes will be like, I saw my therapist and then they're just doing a play session with my kid. Like, why am I coming to therapy? Our kid is just having a play date. I love hearing that, but that is not the case. Yes, our therapy does look like play, and that is the point. That's what we want. We want your kid to be engaged and having fun and participating. But please know that our therapy is always directed for a goal and our outcome. So we are trained and we use our therapy techniques to kind of squeeze them into play, whether it's finding a toy or an activity the kid really likes and twisting it just slightly so that the kid doesn't really notice, but you're still working on our goals. That is my favorite complaint that parents have, is that it's just play. So we really, really try to have a good time and get the kiddo engaged, because if there's not buy-in from the kiddo and they aren't having fun, one, they're going to dread coming to therapy, which is a pain for everybody on all accounts. But two, then they're not really going to participate and they're not going to grow and improve at the rate that we want them to. Not to say that there won't be some screaming and crying sometimes, especially physical therapy. We are working their muscles hard. Sometimes we're stretching them and it's uncomfortable. And it's just like, if I were to tell you tomorrow I'm going to start training for a marathon and going to the gym 4 or 5 times a week when I haven't previously, it's going to really, really stink. And so that first month might be a little transition period, but usually after that month, you see them around a corner, they're starting to get better at these activities. They're starting to see that they can do it. And all of a sudden it turns to maybe a little bit of fussing to like no more fussing. They're engaged, they're having fun. You're going to start complaining that we're just playing. So that's really what the play-based and child-led therapy looks like. MetroEHS is really, really unique because we are able to collaborate with other therapies within our centers. Each therapy center has PT, physical therapy, occupational therapy, speech therapy, applied behavior analysis, as well as mental health. And so we have so many opportunities at our fingertips and resources. It's one of the big main components why I'm at MetroEHS, especially because not many ABA centers do have physical therapy, and it's such a crucial and important part of these kids' lives. Once the ABA part of their services gets them up to speed and gets them engaging with their peers, and so they're going out to recess, but they can't catch a ball. These kids want to play kickball or baseball or Foursquare. I don't know what the kids are into these days. But being able to keep up with the peers at a motor skill level, once they are figuring out how to engage in the right way to give social cues, is so, so crucially important to these kiddos. And it's not just collaboration with other therapies, but also with parents and caregivers and you guys, making sure we are all wrapping our arms around these children as one unit and that we're all on the same page and we're communicating with each other. That being said, if I do have a kiddo that might have potential occupational therapy needs, I love just running next door, literally 5 steps away, and be like, hey, can you take a look at this kiddo? I'm seeing a little bit of this. What's your input? So having those resources right at the center is amazing. And I have seen such a difference in comparison to when I worked at locations that didn't have them all together. And then lastly, at MetroEHS, we do have some special therapy options. I will go through those towards the end, but that is what includes our pelvic floor and potty training. So that is kind of PT at MetroEHS in a nutshell. Some common diagnoses we see, this is not all encompassing. There are almost no diagnoses I have had my team turn away as physical therapists. Maybe once or twice on a blue moon, but in general, we're able to see and treat and bring in any kiddo at any level. These are just the main ones. So we've got Down syndrome, autism, torticollis, brain injuries, gross motor milestone delays. So those are those kiddos that the little ones that might not be sitting up on their own when we want them to, or crawling or walking when they should be. When they get older, it's more of the playground skills. Toe walking, cerebral palsy, enuresis, which is our bedwetting, constipation, genetic disorders, and the list can go on and on and on. So physical therapy versus occupational therapy. There is so much overlap, and this is a common question that I get, so I always like to touch on it. I get questions, how do I know which one my child needs? Does my child need both? They're currently in occupational therapy. Do they need PT? Is it the same thing? Is it different? And there is so much overlap. So both PTs and OTs will look at your child and address very many similar aspects, but in different ways. So we'll both look at balance. We'll both look at coordination. We'll both look at, overall playground activities and everyday activities of daily living. But we might look at it in different aspects. I'm watching their balance. Can they function throughout their environment? Can they step up on a ledge without losing their balance? And OT might look at that too, but they're more so focused on like the activities of daily living. So are they able to balance and maintain single leg stance so that they can put their pants on in the morning? Can they functionally get throughout their day? That's their occupation, is basically living and being a child right now. So that's a little bit of the difference. Something that is unique to physical therapy is more of an in-depth walking analysis and how to adjust and retrain those muscles and joints to help them walk at more of a normalized pattern. And then more unique to occupational therapy, they are the sensory gurus. They can give the sensory input, regulation, sensory diets. I have learned a lot from them. So there's definitely some sensory things that my PT team will integrate as we treat, but really the OTs are the gurus on that. So specialty therapy is offered at MetroEHS specific for PT. We do have a few other areas across the board in other disciplines, but these are all of the ones that physical therapy is incorporated within. We have feeding and swallowing, TheraSU, dynamic movement and intervention, or DMI, and then pelvic floor and toileting. Feeding and swallowing, we have a pretty intensive feeding and swallowing program. It's mostly led by our occupational and speech therapists. They're the ones that are working on that main component of feeding and swallowing, the tongue lateralization, the jaw movements. I don't even know. That's outside of my realm. I could say things that I won't even know them, so I know you guys won't know them either. But that really is taken over mostly by occupational and speech therapy. However, when we have our really medically complex kids, our kids that are super involved, where it's really hard for them to just sit up straight for a period of time, or they're taking all of their energy to sit up straight and hold their neck up straight and keep their head up, their feeding and swallowing goes downhill, because as soon as we ask them to start chewing food or work on swallowing, they're going to use their energy to do that. And then their trunk and core and neck fall apart. And at that point, we start to see the choking issues, the acid reflux, all of those things. So there are times when PTs do intervene to help work on that strength and endurance so that the child can be successful with feeding and swallowing moving forward. TheraSU is another specialty option we have specifically at our West Bloomfield Center. It is an external suit. There's a little picture of our friend Tanner who's wearing it. And it helps the muscles work in their proper alignment. So all those little cords are kind of bungee cords that are going across the suit, and will pull the muscles into their proper alignment and help activate them in the right plane. So that's an option we have. It utilizes a universal exercise unit, or UEU. We like to call it a cage, but we don't love to call it a cage because it doesn't sound great. But in the background of that photo, you can see kind of a cage-like structure. And so that is the UEU that we can use and help facilitate extra movements. And some other kids in the center might use that UEU as well for other therapies. It's not just specific to TheraSuit, but TheraSuit does utilize it quite a bit. TheraSuit is an intensive program and usually runs 3 hours a day for 5 days a week. So this is one of our really intensive programs. And then it's usually only a month at a time. And so people will do this intensive therapy for about a month. And then once it's over, they'll return to their regular typical scheduled therapy 3 to 5 times a week. So it's really just to help boost that kid up, kind of help catch them up in a quick, short time period, and then they can go along with maintaining that. Dynamic movement intervention is a treatment approach that focuses on autonomic and automatic postural responses to improve overall movement patterns. So it's just like if I were to push you to the side, your body is automatically going to adjust and pull itself back to the center. So this is an approach where we use those postural responses to help work on strengthening and balance and core. So this is an option. This is also a potential to be an intensive intervention. Sessions can be up to 2 hours, 5 days a week. It's recommended. We do have one physical therapist that is trained and certified in DMI, and she is at our Plymouth location. So that is an option for our kiddos as well. And then what most of you guys are here for, the gold shining stars, pelvic floor and potty training. So all of our therapy centers has a physical therapist who went through an intensive 18-hour course to be trained in pelvic floor and how we can help our kiddos that have potty training issues or just overall bowel and bladder complications. So our pelvic floor therapy is training the muscles in and around the pelvis to help your bowel and bladder listen to you. We really, really want the kid to be in charge of their own body, right? And not feel like it's outside of their control. You know, I'm having accidents, I can't do anything. We want to give them that empowerment and that control back. Common conditions that you might hear that your doctor says that you or your child might have. We have overactive bladder, so that's needing to relieve yourself often and urgently. Urinary incontinence or enuresis is a decreased ability to control your bladder. Underactive bladder is when you have a prolonged time to empty your bladder, so you're sitting on the toilet for a longer amount of time to empty, and sometimes you might not fully empty it. Dysfunctional voiding is the inability to fully empty the bladder to a more extent than the underactive bladder, which then your bladder is constantly almost half full, and then you have more increased visits to the bathroom. We have stress incontinence, which is leakage secondary to abdominal pressure. So I like to compare your bladder to a balloon. And so you're filling that balloon up. And once it's full, if you put pressure on it, you know, it has that ability to pop or leak. So that's what stress incontinence is, you know, if you're laughing or all that abdominal pressure is pushing down on that bladder, you might have some leaks. Giggle incontinence is specific just to laughing. And this one is commonly linked to genetics. So that is a whole nother realm we can look into. And then lastly, constipation or the inability to empty your bowels consistently. So those are the main common conditions treated as far as pelvic floor and potty training. What is pelvic floor? So pelvic floor is basically a group of muscles and tissues that support your organs in your pelvis. So these are what are going to help you have control of your bowel and bladder. They play a role also in your core strength. And then I already touched on your ability to hold and release urine and feces. So these really, really are huge as far as when we are working on potty training. There's a lot of buildup of if your kid is even ready to potty train, do they have the ability and control of these muscles? Because if they don't, ultimately, they're not going to be successful when you go to potty train them. So what to expect at a pelvic floor evaluation. First, we will gather information and history. This is a big part of pelvic floor therapy, is getting all that information. What have you tried? What haven't you tried? What might have worked for a little bit, but then fell apart? Were there big schedule changes or life changes that really derailed your child? And then the history aspect, some of this is genetic. So is there anybody else in your family that deals with this? So all of that information is really, really vital for us. At the evaluation, we will also assess and look at the sensation and control of the pelvic floor muscles. Are they able to contract and relax? Does your child have the ability to contract them and know they're contracting them, or is it just at random? Do they sense them? You know, can you tell that your bladder is full, or are you just going throughout your day and oops, you have an accident? So really understanding and getting down to the nitty-gritty what is going on within that child. I do want to state that everything that MetroEHS does as far as pelvic floor therapy is external. So there will be no internal exams or treatment. Everything will be done externally. That being said, we still do ask that the parent is present at each session. We want consent every single time we are looking at the pelvic floor muscles. And we do ask that you guys are watching and engaged, not sitting in the corner on your phone. We want you to be aware of what's going on with you and your child, and that you are also up to speed and you agree with what is happening. Moving along, we also will discuss diet and daily schedules. This is such a big role in potty training and pelvic floor training. So much of it can be fixed just with diet adjustments and schedule adjustments. So it does take a lot of buy-in with family, caregivers, even sometimes teachers or whoever else might be in charge or overseeing your child throughout the day. It's really an everybody's on board approach. And we can talk about more of that in the next slide as far as how that can be done. And then lastly, we'll look at core strength because that does play a role into their control of the musculature. So our treatment's a little bit different than the evals. I kind of already touched on, we will be working to properly activate and relax those muscle floors, or the pelvic floor musculature, making sure they understand when they're contracting it, what it feels like, when they're relaxing it, what it feels like. Is it a full contraction? Can they hold that contraction? Or is it like, I can contract it and then it falls apart? So just looking and training all of the muscles in that way, becoming aware of different sensations within their body. I feel like this is such a huge role, especially in many of our kiddos, specifically the ones that have sensory preferences. They might not be aware of what they're feeling, and do they even feel their bladder? Are they even aware that their bladder is giving them feelings? So that is a big thing that we work on with pelvic floor therapy, is starting with sensations. And we work hand in hand with our OTs on this one. There's a whole protocol of, we'll start with what they can see and what's tangible. Touching something cold. Okay, how does that feel on your fingertips? Can you feel it on your skin? Now I'm going to warm it up. How does that feel different? How does it feel the same? So we work on stuff that is tangible and that they can see and feel. And then we slowly work into like the lungs. You can kind of see your chest rise and fall. So that's a little bit easier to see, but also inside their body. So it's going to be a little bit more complex, and then slowly work down into the bowel and bladder and learn, how do we sense and feel how our bowel and bladder is doing inside of us? Scheduling. So this is more of stuff that you guys can take away and start to work on at home. I wanted to give you guys a few tips because I know potty training was one of the big questions that I had seen come up in the form that you guys filled out to sign up to be on this webinar. So toileting, many of our kids need to be voiding or going to the bathroom 4 to 7 times a day. And I know that's a big issue for a lot of our little ones, is getting them to sit on a toilet and go, whether it's the fear of missing out, they don't want to stop playing with their friends, maybe their day is just jam-packed and nobody ever remembers, okay, now we've got to go to the potty. So working on increasing the amount of times they're going to the bathroom. Hand in hand with that, I'm going to jump down to that last bullet point on my diet, is the fluid intake. They need to be drinking 32 ounces of water at minimum each age, potentially more if they're a little bit older. And the more they drink water, the more they're going to go frequently. And so those go hand in hand on how to work towards really retraining and fixing whatever is going on within their bladder system. Other diet adjustments that are things you can start to try at home today. And that's something we can talk more about if you are interested in actual pelvic floor therapy. There's a lot of bladder irritants that we're eating every day that we're not aware of. And it doesn't impact everybody. And it's not to say we need to cut these out of the diets long term, but at least short term, while we're retraining the body to adjust and learn to take control of our bowels and bladders. So the main bladder irritants are a lot of the tomato-based products, caffeine, spicy foods. Milk is like the big one that I feel like a lot of families struggle with. Usually there's a glass of milk at the dinner table. I try to urge to maybe try and cut milk out of dinner and later, like maybe you have milk with lunchtime and maybe with a snack after lunch, but dinner time and later, try to cut out milk. I have found that has helped families a lot just with that one adjustment. Similarly, chocolate goes in that dairy category, so try to cut out chocolate later in the evening. And then red and blue dyes is also some bladder irritants. Common constipating foods are applesauce, marshmallows, cheese, tapioca, and then the really underripe bananas when they're more of that green or light green to yellow area. That's when they can be constipating. And then other diet adjustments we look at is fiber intake, and I already mentioned the fluid intake. So those are kind of the main things we look at. Again, pelvic floor and potty training is such a all hands on deck approach. You have to be willing to make these schedule changes, make these diet changes. And we can be successful if we can't be super consistent, but it's going to take a lot longer. And most of the times I see some improvements, but it's not until everything is falling into place and totally on board that I really see the full improvements and I can graduate people out of physical therapy. Some other tools to help to give you guys right off the bat is if you do come in for pelvic floor therapy, our therapist can create a letter of medical necessity for, your caregivers, your teachers, or other providers. If we're talking about like, we need to schedule toileting, every hour initially or every other hour, and it's something that the kiddo just doesn't do on their own because they don't want to miss out on what's going on in the classroom, or it's recess time and that 2 minutes of recess, they really want to get there. So it's working with the caregivers or the teachers or who might be in charge of your kid throughout the day and getting them on board and creating a schedule with them of what's going to be successful so that we can help this kiddo get past this place in life. I know a lot of families have found success with potty training watches. There's a few different ones online. You can look into them. Some will just vibrate and that's it. And so that can trigger your kiddo to go. Sometimes I've had the teachers wear the watches so that they're triggered to kind of tap on the shoulder of the kiddo and let them out the room. So there's different ways you can utilize those watches as well. Water bottles. I know some water bottles have like the different lines of like, this is where you should be in the morning and the afternoon. So sometimes I've had parents like just buy a generic water bottle and write on it with Sharpie or something of like, I want you to be here by recess and here by activities and here by whatever other subject, or different times throughout the day. So that's an option to look into. I know my few older kiddos, the Stanley Cups are hot right now. So I have made deals with parents of if you buy the Stanley Cup for your kid, they're going to drink more water. And then maybe we can have buy-in from them because sometimes it is like, I only have 5 minutes between classes to get from point A to point B. I don't want to drink more and have to go to the bathroom. But maybe that Stanley Cup will be that icing on the cake. Sticker charts are a big one. I know that's a pretty commonly known and heard about option. But I always like to put it out there as well. Sometimes I give these to the teachers too to help them track throughout the day so that they can report to the families and to myself at the end of the week of how the week went. And then squatty potties. I know this was kind of playing into one of the questions somebody had presented, but they said, their child is always kind of squatting or getting into a deep squat position in order to have a bowel movement. Is this normal? Absolutely normal. Squatty potties sometimes are the answer you need. The way our pelvis is positioned and the way our bowels are positioned, the best way to release and open up that floodgate, for lack of a better term, is to have that little footstool at the bottom of the toilet that puts your legs and hips kind of over that 90-degree angle, which will help open up everything in them and help them relax a little bit more so that they can get things flowing. So sometimes that is the easy answer. So that's an option. Something I didn't include in the text that just came forefront of mind is blowing objects, like blowing candles, blowing bubbles. That motion helps the diaphragm push into everything, and that will also help release. So that's an activity. I know my niece was somebody who would blow bubbles while on the toilet because it helped her get things moving and push through. So that's an option to try at home as well, especially if you are struggling with the bowel movements, is grabbing a little thing of bubbles and they can blow bubbles while they're sitting on the toilet. Sometimes it is a little bit more distracting. So there's pros and cons to it, but it's an option to try. All right, that was a loaded, quick little presentation. I will open it up for questions and answers, but we also, if this is something you're interested in as far as general therapy, or I know a lot of you guys were interested in the pelvic floor and potty training. We do have some open slots available, so feel free to give us a call. Our number is on the phone, and we're able to get you scheduled when we can. So I want to open it up as well. Do we have any questions from anybody that would like to speak up? All right. Well, I hope this was helpful. Again, feel free. I know the recording will be sent out. We're also going to try and include my email. So if you guys do have any lingering questions or you want to reach out individually, feel free. I'm more than happy to help out and answer questions as best as I'm able to.
Kelly, I want to ask you a couple questions before we let you go. Let's look at some of the ones that came in. Can you give us a couple of tips about what it would be like to potty train a nonverbal child? And the particular question, the kiddo's 3 years old.
And 3 years old, it's really on that cusp of, I know a lot of, especially, you're getting your kid to preschool around that age, and they really want your kid to be potty trained, but most kids aren't really ready until 4 to 5 years old. So it might just be it's a little too early for your kid. But tips and trips, I know a lot of times for our nonverbal friends, it's more on the parents, the scheduling, the getting them to the toilet and having them sit. Using the watch throughout their day is really helpful. And it's usually an all-team approach. That's hard because I'm not sure cognitive level of the kiddo too. Is it just a nonverbal situation, or is there more going on? Can they cognitively listen and understand to directions? Can I address them to do and try certain things, or is there more going on with that kiddo? But I've seen families with like the sticker chart and the potty watch be successful with kiddos that are nonverbal, and there's other things we could try as well.
Okay, great. What about, is it best, and you kind of touched on this a little bit, I think, but is it best to block out a designated set of days to tackle potty training? Or is there like, what is the magic number, or how often do you face this with the kiddo?
That is a great question. And I think it varies by parenting style as well. Some families, they block, especially if you're a teacher and you have spring break off, you're like, this is the week, we're going to do it. And I've had parents be successful both ways. So it really is up to you and what you're able to do and the time you're able to commit to it. I know there are a few different potty training ways to do it online. I've had parents say, oh yeah, we bought this program online. It's a 5-day thing and it's like money back guarantee, we're doing it. And that's awesome. And sometimes it is just trying to figure out the schedule and the training and getting consistency so the kiddo can learn and navigate that. But sometimes it is deeper than that, and there is more just body awareness and control of the musculature. And so you could try that as much as you want, but if that kiddo isn't really ready and set up for success, ultimately that might not work. So it really is a case-by-case basis and parenting style. Some families are gung-ho, let's do the 5 days or 7 days, whatever program you might find out there. And some are like, that's way too intense. I don't have the time or energy or resources to make that happen. So it depends.
So if you had to say 3 ways, like what are the 3 signs you look for a child who is ready to potty train? What would you say?
That really takes more of like an in-depth assessment, I would say. But if they are starting to be aware and they're saying, oh yeah, like if they're still in diapers, like I went potty, I need to change a diaper. When they're starting to verbalize, like they're understanding that they just went and they're feeling that their diaper's wet and they're starting to pick up on those sensations, or like sometimes it's like, oh yeah, I have to go, but then they're going in their diaper still. Those are some really good cues that you're getting really close to being ready to potty train, and you could even probably start dabbling in that.
Okay, good. And you talked about the little squatty potty. That was so funny and so helpful. And somebody had asked about that. Okay, great. Well, do you have any like encouraging words for parents who are right in the middle of the throes of potty training? What are their signs to know there's something bigger going on, like maybe the pelvic floor, so that they can come your way?
I would say if your kiddo isn't able to, whether it's showing you signs if they're nonverbal or verbally stating that they're feeling things and understanding what's going on in their body or recognizing that they just had an accident, that's when I would reach out and look deeper, because it's probably they're not able to talk to their body, and they should be able to. I should be able to tell my bladder, hold on, I know I've got 5 minutes left of this presentation, you can make it. Where some of those kids, it's like, oh, I feel I gotta go, and then they go. So it really depends, but if you feel like you've tried a few different things and there's still like not even a sliver of progress or a glimmer of hope, then there's probably something else going on. And that's when I would get them looked at. You can either bring them in straight for a pelvic health physical therapy evaluation. Some people go the route of GI doctors or other options your pediatrician might refer out to, but ultimately it might end up back with us anyway. So feel free to reach out.
Okay, well, great. Thank you so much, Kelly. We appreciate your time, and we'll be sending this out to everybody. And I know you said to me earlier that it was fine to send your email, so we'll send that along with them. But
Awesome.
thanks so much for joining. I'll see you guys
Thank
later.
you.